So our lecture today is about the intracranial pressure and the cerebral perfusion. Now I will share my screen to start it. So what is intracranial pressure? It's the pressure inside the intracranial cavity. Why is this pressure important? As you know, if there is high intracranial pressure or the pressure gets high, this will impede the blood flow inside the intracranial cavity, which may lead to ischemia. Now, how does that happen? As you know, in physiology, we remember this equation, which is this equation that the perfusion or the blood flow, this equation is in physiology, the blood flow in any tissue equals what? It equals the delta pressure, which is equal almost it's a pressure, the arterial pressure. It's a delta pressure, the pressure difference, but we can say it's the arterial pressure because the venous pressure is negligible. So it's usually the mean arterial pressure over the vascular resistance. And as you know, the vascular resistance depends on the arterioles and the caliber of the arterioles mainly. So if there is vasodilation, the resistance will be down. If there is vasoconstriction, the resistance will increase. So blood flow equals pressure over resistance. This is the general rule for any tissue in the body. Okay. Now, what about the intracranial cavity? Okay, imagine this is an arterial wall here. Okay. So what is the pressure inside the lumen? It's the mean arterial pressure. It's the pressure usually inside the lumen. What if the tissue, what if pressure is exerted on the tissue from outside? I mean, what if the whole tissue gets increased in its pressure? Like if the tissue is in a cavity and this cavity becomes pressurized, what will happen? So there is external pressure here. So there is pressure also here outside the artery here. So there is pressure inside the artery, which is the mean arterial pressure, and there is pressure outside. Now, in the case of the brain, the pressure outside the artery, what is the pressure outside the artery? It's the intracranial pressure. Okay? So what happens here? If the intracranial pressure gets increased, what will be the equation? Okay, so the normal equation, as you know, the normal equation, the pressure is the mean arterial pressure, and the resistance is the vascular resistance. Okay. Now, in case of the intracranial cavity, we subtract intracranial pressure from the mean arterial pressure. Why do we do that? Because the effective pressure for the blood flow is the difference between the pressure inside the artery and the pressure outside the artery. So the pressure outside the artery is the intracranial pressure here, and the pressure inside the artery is the mean arterial pressure. And this is called the cerebral perfusion pressure. The cerebral perfusion pressure. So the equation becomes like this, that the cerebral blood flow equals the cerebral perfusion pressure over the cerebral vascular resistance. And the cerebral perfusion pressure equals the mean arterial pressure minus the intracranial pressure over the cerebral vascular resistance. What does that mean? Now, what does that mean? This means that if the intracranial pressure increase here, what will happen? If the intracranial pressure increase, the cerebral perfusion pressure will be down because the cerebral perfusion pressure is the mean arterial pressure minus the intracranial pressure. And in this case, the cerebral blood flow will be decreased. This will lead to ischemia. Okay? This will lead to ischemia. Now, this means that the intracranial pressure is very important because increased intracranial pressure, as we said, will lead to decreased cerebral perfusion pressure, which will lead to decreased cerebral blood flow at the end. Now, all what we said till now about the blood flow in the tissue is about mechanics, about the physics. So in physics, the blood flow equals pressure over resistance, the cerebral perfusion pressure over the cerebral vascular resistance. This is physics, pure physics. But what about the biology? What about the biology? How does the tissue regulate its blood flow? According to what? So it's according to the metabolic demand. It's according to the metabolic demand. So any tissue regulates its blood flow according to the metabolic demand. Okay? How does that happen? Now, any tissue regulates the metabolic demand according to its need. Any tissue regulates the blood flow inside it according to its metabolic demand. And the tissue controls this by controlling the vasodilation and the vasoconstriction. It means by controlling the resistance, by controlling the resistance. So, if the metabolic demand increases, what will happen? If the metabolic demand increases, CO2 will build up, pH will be down, and this will lead to vasodilation. It will lead to decreased resistance, and at the end, it will lead to increased blood flow. Okay? This will lead to increased blood flow at the end. So, the metabolic demand is the basic thing. On the other hand, if the metabolic demand decreases, the CO2 will be down, the pH will increase. This will lead to vasoconstriction and increased resistance, and this will decrease the blood flow. So the blood flow always is regulated by the metabolic demand of the tissue. And this phenomenon is called autoregulation. What does autoregulation mean? What does autoregulation mean? Autoregulation means that the tissue regulates the blood flow inside it according to its metabolic demand. Okay, regardless of the blood pressure. Now, here comes the question. What if the metabolic demand is constant? What if the metabolic demand is constant and the mean arterial pressure increases if the pressure increases, while the metabolic demand is constant? When the mean arterial pressure increases, actually, the tissue will respond by increasing the resistance in order to keep the blood flow constant. Because the metabolic demand is constant, the blood flow needs to be constant. So if the blood pressure increases, the tissue will increase its resistance in order to compensate and keep the blood flow equal to the metabolic demand of the tissue. And this is also called autoregulation. So in the brain, if usually the metabolic demand of the brain is constant usually. So if the mean arterial pressure increases, then the cerebral perfusion pressure will increase. The response of the vasculature of the brain will increase the cerebral vascular resistance in order to maintain the cerebral blood flow constant. And this is called autoregulation, as we said. It's called autoregulation. Now, we can see this by the graph. Now, cerebral oxygenation depends on the cerebral blood flow. The cerebral blood flow equals the cerebral perfusion pressure over the cerebral vascular resistance, as we said. The cerebral perfusion pressure equals the mean arterial pressure minus the intracranial pressure, as we said. So in summary, if the intracranial pressure increases, this will lead to decreased cerebral perfusion pressure. This will lead to decreased blood flow and decreased tissue oxygenation, which can result in tissue damage, ischemia, and anoxia. Okay? So the brain needs autoregulation. Autoregulation, as we said, is the mechanism by which the brain maintains a constant blood flow according to its metabolic demand, regardless of the changes in the blood pressure. And this graph can demonstrate this. Look here, the x-axis is the cerebral perfusion pressure. In physiological condition, the cerebral perfusion pressure is almost equal to the mean arterial pressure because the intracranial pressure in physiological condition is near zero. So this is the cerebral perfusion pressure or the mean arterial pressure, and this is the cerebral blood flow. The y-axis is the cerebral blood flow. As you see here, that regardless of the blood pressure, the cerebral blood flow is constant here. So the cerebral blood flow is constant. How does that happen? As you see here, when the blood pressure increases, there will be vasoconstriction here. So while the arterial pressure increases, there will be vasoconstriction and increased cerebral vascular resistance in order to maintain the cerebral blood flow constant, regardless of the blood pressure. Vice versa, when the blood pressure decreases or the cerebral perfusion pressure decreases, there will be vasodilation in order to compensate and keep the cerebral blood flow constant regardless of the cerebral perfusion pressure. This is called autoregulation. But as you know, any physiological mechanism, any physiological negative feedback mechanism has some limits. Anyone has limits. So what will happen if the cerebral perfusion pressure increases above 150 millimeter mercury? So the autoregulation is between 50 and 150 millimeter mercury usually in physiological condition. What happens if the mean arterial pressure increases above 150 millimeter mercury, like in hypertensive crisis, for example? What will happen in this case? Actually, in this case, the artery tries, the arterioles try to vasoconstrict, but it cannot. Why? Because the smooth muscle in the wall of the arteriole has limited strength of contraction, So what will happen here? The arteriole tries to constrict against the high blood pressure, but the intraluminal pressure here is very high, so it will open it. The intraluminal pressure is high, so it will open the arteriole forcefully. So here, what will happen here? There is forced vasodilation. The arteriole tries to contract, but it cannot due to the high intraluminal pressure in the arteriole. So there will be forced vasodilation. This will lead to increased blood flow to the brain more than its metabolic demand, and this is called hyperemia. Hyperemia means blood flow inside the tissue more than the physiological need of the tissue. This will lead to hyperemia, and this hyperemia will lead to capillary leak of the fluid, and this will lead to vasogenic edema because the plasma will leak from the capillaries to the interstitial fluid and it will result in edema. This is called vasogenic edema. Actually, this happens in the hypertensive crisis, and it is called, the clinical scenario is called acute hypertensive encephalopathy. Acute hypertensive encephalopathy. This is part of the malignant hypertension or hypertensive crisis syndrome. The patient comes with headache and usually with blurry vision. Why blurry vision? Because the vasogenic edema happens more in the occipital lobes, which is responsible for the visual cortex and the vision. So the patient with hypertensive crisis usually comes with blurry vision and headache due to the hyperemia in the brain, especially in the occipital lobes and the vasogenic edema that happens there. On the other side, what will happen if the cerebral perfusion pressure drops below 50 millimeter mercury? Actually, in this case, regardless how much the smooth muscle in the walls of the arteriole will relax, but the pressure, the intraluminal pressure, is not enough to open the arteriole in this case, because it has elasticity. So the arterial wall will relax in attempt to vasodilate, but the intraluminal pressure is not enough to keep the arteriole open. So there will be forced vasoconstriction, and in this case, the blood flow will drop below the physiological need, below the metabolic need of the tissue, and this is called ischemia. Actually, ischemia, prolonged ischemia for several minutes will lead to energy failure in the tissue because there will be decreased oxygen supply and decreased glucose supply. This will lead to decreased production of ATP, and this will lead to failure of sodium-potassium ATPase pump in the plasma membrane of the cells. And this will lead to sodium influx inside the cells. And as you know, by osmosis, the fluid will follow the sodium and it will lead to intracellular edema. And this is called cytotoxic edema. Cytotoxic edema is edema caused by failure of sodium-potassium ATPase pump and osmosis. It is intracellular edema, and it's called cytotoxic edema that results from ischemia. So as you notice, both sides can lead to brain edema, but different type of edema. Ischemia can result in cytotoxic edema, while hyperemia can result in vasogenic edema. Okay? Now, it's worth mentioning also that this curve is in the physiological brain, not in the injured brain. If the brain is injured, for example, if the brain has some contusion, trauma, any insult in the brain, the zone of autoregulation will shrink. It will be not from 50 to 150, it will be just from 50 to 70, the autoregulation phase. So if in the part of injured brain, in the injured brain part, if the cerebral perfusion pressure increases above 70 millimeter mercury, this will lead to vasogenic edema due to capillary instability due to the insult, and below 50 also will happen ischemia. So if the brain is injured, like in traumatic brain injury, for example, we will have very narrow range for controlling the blood flow to the brain, for controlling the cerebral perfusion pressure and the blood pressure, because we have narrow range for the cerebral perfusion pressure, which is just from 50 to 70 rather than from 50 to 150 in physiological conditions. Okay, so 50 to 150 millimeter mercury in physiological conditions, and 50 to 70 millimeter mercury in injured brain. And that's why controlling the cerebral perfusion pressure and the blood pressure in a traumatic brain injury is very important. We don't want ischemia to happen, and we don't want hyperemia to happen. This is the same thing, actually. Now, all what we said till now is about the cerebral blood flow regulation. Now, we will come to another issue, which is the intracranial pressure regulation, how the intracranial pressure itself is regulated. Just to remind you, if intracranial pressure increases, this will result in decreased cerebral perfusion pressure, which will result in decreased cerebral blood flow and may result in ischemia. That's why controlling the intracranial pressure is very important. And now we will study how intracranial pressure is controlled. Actually, as you know, the intracranial cavity is different from other cavities because it's not expandable. It has just a specific volume. Not like the introthoracic or abdominal cavity, for example, they can be expanded, but the intracranial cavity cannot. It is in a closed skull. We don't have elasticity. And that's why the intracranial volume in total is fixed. It's almost 1,700 cc. And this space is occupied mainly by three components: the brain parenchyma, which is almost 1,400, and the blood in the vessels volume, which is almost 150 cc, and CSF volume, which is almost 150 cc. And this CSF volume is distributed between the intraventricular volume and the subarachnoid space volume. Okay, so we have three main components inside the intracranial cavity: the brain parenchyma, the blood volume, and the CSF volume. Now, here's the question. What if there is mass inside the brain? I mean, what if a volume is added to the volume which is there? What if there is a tumor? There is hematoma, for example, abscess, edema, hydrocephalus, anything which has a volume which can be added to the volume. What will happen? Actually, it will have no space to be added. Why? Because the intracranial volume is constant. There is no extra volume for the added mass. If there is mass inside the brain like hematoma, tumor, etc., what will happen? There is no extra space in the brain. So what will happen? So logically, if we add a volume to a liquid, this liquid will be shifted outside from this cavity. What will happen? We have just limited space here. So this is the brain parenchyma. This is the normal condition. This is the brain parenchyma. This is the cerebrospinal fluid. This is the arterial blood. This is the venous blood. So here comes a mass, and this mass can be anything. It can be mass, abscess, tumor, hematoma, edema, and any added volume. What will happen? So the total volume is limited. It's just 1,700 cc. So when this mass is added, there should be a shift of some other components outside the intracranial cavity. And this is called Monro-Kelly doctrine. Monro-Kelly doctrine. What will happen? From those components, what are the components that can easily get outside the brain? That can easily, because theoretically any component can come outside the intracranial cavity in one way or another, but some components gets out easily and some components they get out hardly, just if the intracranial pressure is increased to a very, very high level. So actually CSF can escape from the intracranial cavity, but how? As you know, the subarachnoid space of the brain is continuous with the subarachnoid space of the spine through the foramen magnum. Again, the subarachnoid space of the brain of the intracranial cavity is continuous with the subarachnoid space of the spine through the foramen magnum. This means that the CSF of the intracranial cavity can shift to the spine because the spinal cavity has elasticity, not like the intracranial cavity. The spine has some ligaments between them, ligamentum flavum, foramina. So there is some elasticity in the spine. So the CSF, the intracranial CSF in the subarachnoid space can escape through the foramen magnum to the subarachnoid space of the spine. This is one way. Another way is the venous blood. As you know, the venous blood pressure is low. So if there is mass, the veins can collapse, and this venous blood can escape through the jugular vein, through the jugular foramen to the jugular vein and to the heart. So those two ways, the venous blood and the CSF, can escape easily from the intracranial cavity. Now, what about the arterial blood? Actually, the arterial blood cannot escape from the brain unless the intracranial pressure is above the mean arterial pressure, and this means that there will be total ischemia to the brain and very high intracranial pressure. So it's not easy to happen. It happens just in very, very high intracranial pressure, and in this case, there will be already brain herniation and brain death actually. And the brain parenchyma, the same thing. It's not easy to escape. The tonsils of the cerebellum, for example, can escape through the foramen magnum. This is called tonsillar herniation, which may happen. So the brain also can escape, but just if the intracranial pressure is very, very high. And in this case, it's called brain herniation, and it will lead to brain death. So CSF and venous blood can escape easily. Other components cannot escape easily from the intracranial cavity. So in the intracranial cavity, we have some reserve of the CSF and the venous blood, which can escape from the intracranial cavity to outside. Okay, and this reserve is limited because the CSF volume in the subarachnoid space is limited, and the venous volume is also limited. This will lead to what? Now, this curve is about the relationship between the volume of the mass and the intracranial pressure. The x-axis is the volume of the mass. The intracranial pressure is the y-axis here. So what will happen when the volume of the mass is increasing? As the volume of the mass increases initially, the intracranial pressure will remain constant. Why? Because there will be compensation from the CSF and the venous blood. CSF will escape to the spinal space, and venous blood will escape to the jugular vein. So as the volume of the mass increase, the CSF will escape and the venous blood escape until the reserve of the CSF and the venous blood is consumed. And this is called the point of decompensation, because beyond this point, any increase in the volume of the mass will lead to increase in the intracranial pressure. Okay? And at some point here, as you see, this curve is exponential curve. It's called exponential curve. So at some point here, for example, 1/4 of cc, for example, very little amount of volume may increase the intracranial pressure to a very high level because it's an exponential curve. That's why the point of decompensation is very, very important. And at the end, it will lead to herniation. Now, we need to relate this curve to clinical scenario. Why is this curve very important? Because, for example, you may have a patient in the ICU or in the ER. The patient is fully conscious. He is clinically well, but there is a mass inside the intracranial cavity which is increasing in its size, and the patient is conscious. Why? Because he has compensation. But all at a sudden, the patient deteriorates and gets into coma. Why does that happen? Why conscious patient suddenly gets into coma? Because as the volume of the mass increases, the patient will reach the point of decompensation, and beyond this point, the intracranial pressure starts to increase dramatically. That's why it's very important to be cautious and to monitor the patient very closely if the patient has a brain mass or increased intracranial pressure from any cause. What are the examples of this? For example, the lucid interval in the epidural hematoma. As you know, the epidural hematoma is a mass. Epidural hematoma is usually from arterial bleeding source, and this means that the volume of the epidural hematoma, which is arterial, usually increases with time because the arterial pressure is high and it will not stop, not like the venous pressure, which can stop by tamponade, but the arterial pressure is high. So if the middle meningeal artery is injured, for example, it starts bleeding in the epidural space. It starts compressing the brain, and its volume increases with time as the middle meningeal artery is bleeding. And the patient is usually conscious in this phase. This is called the lucid interval. But all at a sudden, the patient deteriorates. All at a sudden, the patient deteriorates because the patient reaches the point of decompensation. So lucid interval of the epidural hematoma is an example of this curve. It's worth mentioning that some pathological conditions are more serious than other. One of them is the epidural hematoma because it's arterial bleeding usually. And another case is the obstructive hydrocephalus. It's very dangerous. Why? Because in obstructive hydrocephalus, we will lose one of the mechanisms of compensation, which is the CSF. Why do we lose this mechanism of compensation? This is because the CSF escapes from the subarachnoid space of the brain to the subarachnoid space of the spine. But in obstructive hydrocephalus, the CSF may not reach the subarachnoid space. The obstruction may be proximal to the subarachnoid space, and it will not reach. So we will lose one of the mechanisms of compensation. That's why it's dangerous. Another reason for making it dangerous is that the physiology of the CSF production, as you know, is pressure independent. CSF is secreted from the choroid plexus not by filtration, but by active secretion. This means that if the intracranial pressure increases, the CSF production rate will remain constant because it's active secretion. It's not filtration like the kidney. It's active secretion. Regardless of the pressure, the production of the CSF will remain constant at a constant rate, regardless of the obstruction. That's why in obstructive hydrocephalus, it's very, very dangerous, and the patient may reach the point of decompensation rapidly. Also, it's worth mentioning that at some point here, after the point of decompensation, at some point, the intracranial pressure will increase. This means that the cerebral perfusion pressure will decrease. This will lead to cerebral ischemia. And as you know, ischemia results in what? Ischemia can result in cytotoxic edema. And cytotoxic edema is a volume. Cytotoxic edema is a volume which will be added to the volume of the mass. This added volume will increase the intracranial pressure more and more, will lead to more ischemia, more cytotoxic edema, then more volume, more intracranial pressure, etc., etc. It's a vicious cycle. It's a vicious cycle. And once the patient reaches this point of vicious cycle, it's irreversible. It's irreversible. It will continue until brain herniation and brain death. That's why we should be very cautious. We should be very prompt and very rapid in treating the patient. Do not wait, because you don't know when this point will happen. At some point, the patient will reach this vicious cycle. So be prompt in treating the intracranial pressure when it is high. It's very dangerous. What about the normal intracranial pressure? Actually, those figures are in the supine position, because in erect position they are less than this. This is in supine position. For adults and older children, it's almost between 10 and 15 millimeter mercury. In young children, between 3 and 7 millimeter mercury. And in infants, it's almost between 1.5 and 6 millimeter mercury. Now we will talk about the causes of the increased intracranial pressure. What is common between those causes? The answer is volume. Volume, mass volume. Any volume which is added can lead to increased intracranial pressure, because you notice from this curve that intracranial pressure is related to the volume of the mass at the end. So any volume which is added can lead to increased intracranial pressure. First, cerebral edema. It's a volume. Hyperemia. It will lead to vasogenic edema, which is also volume. And this can happen due to the vasomotor paralysis also. As you remember, we said that the autoregulation happens in physiological condition between 50 and 150 millimeter mercury. But in injured brain, vasomotor paralysis will happen, and this will lead to decreased range of autoregulation. It will become between 50 and 70 millimeter mercury due to vasomotor paralysis. And this is called loss of cerebral autoregulation. So the range for autoregulation will be less in traumatic brain injury, and maybe more significant than edema in raising the intracranial pressure. Traumatically induced masses can increase intracranial pressure, like epidural hematoma, subdural hematoma, intraparenchymal hemorrhage, contusion, foreign body, depressed skull fracture. All those are volumes that can lead to increased intracranial pressure. Hydrocephalus, it's a volume. Hypoventilation. Hypoventilation will lead to accumulation of CO2 in the body. This will lead to high level of CO2. And this high level of CO2 is read by the arterioles as increased metabolic demand. It's not real increased metabolic demand. It's not real increased metabolic demand, but the systemic hypercapnia is read by the arterioles as if there is increased metabolic demand. It will lead to vasodilation, and this will lead to increased intracranial pressure. And we'll mention here that hypoventilation also can happen in injured patient. Actually, in multi-trauma patient, if the patient has high energy trauma, multi-trauma, multi-systemic trauma, the brain is affected not just by the head injury. The brain is affected not just by the head injury, but also by the systemic injuries. How? For example, if there is external or internal hemorrhage, this means that hypovolemic shock may happen, and hypovolemic shock will lead to decreased blood pressure, which will lead to cerebral ischemia and will result in brain insult, anoxic brain damage. If the patient, for example, has hemothorax, pneumothorax, lung contusion, anything which affects ventilation, this will lead to hypercapnia, which will increase the intracranial pressure and will aggravate the condition. If the patient has head trauma, any traumatically induced mass, this increases the intracranial pressure, which will decrease the cerebral blood flow and will lead to brain ischemia. So in the multi-trauma patient, the brain is affected by many factors. By the head trauma itself, which can increase the intracranial pressure, by hypotension due to any reason, hypovolemic shock, obstructive shock by cardiac tamponade, for example, by hypercapnia due to hypoventilation because of any chest trauma. So all those factors can gather and lead to injury of the brain, not just the head trauma. And that's why many multi-trauma patients can end up with brain death due to those reasons, because anything can affect the brain, whether it's hypovolemia, hypotension, hypercapnia, and the head trauma itself. Now, systemic hypertension is one of the causes of increased arterial pressure. As we said, in the hypertensive crisis, acute hypertensive encephalopathy can happen due to the vasogenic edema, due to failure of autoregulation above 150 millimeter mercury for the mean arterial pressure. Venous sinus thrombosis can lead to impaired venous drainage of the brain, and this will lead also to increase intracranial pressure. What about the Valsalva? Valsalva means anything which increases the pressure inside the thoracic cavity. This will be reflected over the intracranial pressure. Why? Because when the intrathoracic pressure increases, this will lead to decreased venous return to the heart. This will lead to build up of pressure in the jugular veins, and this will lead to decreased venous drainage of the brain and will lead to increased intracranial pressure at the end. So any Valsalva maneuver, anything that increases the intrathoracic pressure, this pressure can be reflected over the intracranial pressure. For example, what are the examples of Valsalva maneuver? For example, coughing, sneezing, gagging, straining against constipation, straining against urine retention, gagging due to endotracheal tube, coughing due to endotracheal tube, stress. So that's why traumatic brain injury patients should have some type of sedation to prevent having this Valsalva maneuver. Should be aware, any patient who has brain insult, intubation should be smooth with muscle relaxant. Extubation also should be smooth to avoid having Valsalva maneuver. If the patient blood pressure is good, he should have good sedation to prevent gagging and coughing. And the patient also, if he is bedridden, should have laxative to prevent constipation. He should have Foley's catheter to prevent urine retention, because all those factors, the straining, the coughing, sneezing, gagging, can lead to increased intrathoracic pressure, and it will be reflected to the intracranial pressure. You should be aware of that. What about the sustained post-traumatic seizure, the status epilepticus, for example? The status epilepticus actually increases the metabolic demand of the brain, which can aggravate the condition. Also, status epilepticus can be tonic and can lead to Valsalva maneuver. So there are many factors. And also, status epilepticus can stop the ventilation, and it will lead to hypoxia and hypercapnia and aggravate the condition. So by several ways, status epilepticus can lead to increased intracranial pressure, whether by Valsalva, whether by hypoventilation, whether by hypoxia, whether by increased metabolic demand of the brain itself. Now, here comes this issue, the clinical presentation of intracranial hypertension. First thing is vital signs. So 1/3 of the patients of increased intracranial pressure will develop what is called Cushing triad. Hypertension with bradycardia with respiratory irregularity. Hypertension, bradycardia, respiratory irregularity. Now, if those happen, this is Cushing triad, it can implicate high intracranial pressure, but the sensitivity is low. Just 33% of patients of high intracranial pressure will develop the Cushing triad. That's why you cannot depend on Cushing triad for monitoring the patient for developing high intracranial pressure. So Cushing triad is specific if it happens, but it's not sensitive to monitor the patient. Decreased level of consciousness. This is the most important way to monitor the patients for developing high intracranial pressure. It's the Glasgow Coma scale, the level of consciousness. If the traumatic brain patient has drop in the Glasgow Coma scale 2 levels below the baseline, 2 score points below the baseline, you should expect that the patient developed increased intracranial pressure, and the patient should have an UCT to check for this. So level of consciousness, the Glasgow Coma scale, is very, very important in monitoring those patients with head trauma. Now, if you see in the wards, for example, a patient who has head injury is under observation in the hospital, and this patient should be awakened almost every 1 hour or 2 hours to check the level of consciousness. We do not let those types of patients to sleep for a long time. Why? Because we don't want the patient to be in coma and decrease level of consciousness without noticing that. That's why we always awaken the patients with traumatic brain injury every now and then to check the level of consciousness. Now, the level of consciousness, we can depend on the level of consciousness for monitoring the intracranial pressure given that the patient is already conscious. If the patient is already conscious, you can easily notice if the patient develops decreased level of consciousness. By this method, we can monitor the patient for intracranial pressure. Now, here comes the herniation syndromes, and it's not the tonsillar herniation we talked about. Actually, it's compartmental herniation. It's internal herniation between compartment and another compartment of the brain. This will result in anisocoria, fixed dilated pupil unilateral. Now we will talk about it. Now, all what we said till now about the intracranial cavity was as if the intracranial cavity is one cavity. But in real, it's not just one cavity, it is three cavities. How is that? The intracranial cavity is divided into three compartments by the falx cerebri and the tentorium cerebelli. Now, the falx cerebri and the tentorium cerebelli are composed of dura mater. And dura mater is non-elastic. Dura mater is non-elastic. So the falx and the tentorium separate the intracranial cavity into three compartments, into three pressure compartments. The right cerebral hemisphere, the left cerebral hemisphere, and the posterior fossa. The posterior fossa is composed of the cerebellum and the brainstem. Okay, so three compartments inside the intracranial cavity: the right cerebral hemisphere, the left cerebral hemisphere, and the posterior fossa. Now we will concentrate here on ankle herniation because it's very important. For example, if the patient develops mass here, like epidural hematoma on the left cerebral hemisphere, it will compress the left cerebral hemisphere. If the right cerebral hemisphere and the posterior fossa have normal pressure, there will be compartmental difference in the pressure. This will lead to part of the temporal lobe called the uncus to slide below the tentorium and go to the other side. By its way, it will compress the third cranial nerve, the oculomotor nerve, and the cerebral peduncle. By compressing the third cranial nerve, the first fibers to be affected are the parasympathetic fibers in the oculomotor nerve. As you know, the parasympathetic fibers in the oculomotor nerve are responsible for pupillary constriction. So, if there is pressure on those parasympathetic fibers, this will lead to fixed dilated pupil ipsilateral to that side of the lesion. And if the other pupil is normal, this is called anisocoria. Anisocoria means unequal pupil. An means not, iso means equal, coria means a pupil. So anisocoria, unequal pupils. And it happens ipsilateral to the lesion. Okay? What should you do if you have a head trauma patient with anisocoria? The answer is, if the patient with head trauma has anisocoria, given that ABC are normal, so we go A, B, C, D, E, as you know, airway, breathing, circulation, disability, E, exposure, and secondary survey. Now, pupils are in the D part, in the disability part. Intracranial pressure is in the D part. Intracranial lesions are in the D part. So ABC is more important is more prior to D. Okay, so we don't overcome those priorities. It's airway, breathing, circulation, then disability. Glasgow Coma Scale is in D, in disability. Anisocoria is in D, disability, okay? So, if the patient with normal ABC, with normal airway, normal breathing, normal circulation, develops anisocoria, this patient should immediately have CT and in the same time be prepared for surgery. So do CT brain and in the same time prepare the patient for surgery. So why is that? Because the patient mostly have ipsilateral lesion to that pupil, and CT is for planning where to open and to remove the lesion, whether it's epidural hematoma or subdural hematoma or etc. Okay, so remember that. Anisocoria, prepare the patient to the surgery, in the same time do CT. Historically, in the era when there was no CT, what did the people use to do for anisocoria patients? At that era, when a patient used to come with anisocoria without, and there is no CT brain at that era, from head trauma, they used to do what is called exploratory burr-hole. Exploratory burr-hole. They drill a burr-hole to search for the hematoma. If it's not there, they will drill another burr-hole, until they find the trauma. Then they connect between those burr-holes in order to do craniotomy and evacuate the lesion. But at the current area, when the CT is available, you don't need to do exploratory burr-hole. Just go for CT. CT is very rapid. You can do it within minutes, and then bring the patient to the OR to remove the lesion. Now, if the patient is conscious or semi-conscious, you can monitor the Glasgow Coma Scale to monitor the intracranial pressure. But what if the patient is already in coma, already on endotracheal tube, for example, or on muscle relaxant? How can you monitor the level of consciousness? Maybe you cannot. So how to monitor the intracranial pressure in this case? The answer is we have some invasive measures for monitoring the intracranial pressure. We insert a probe inside the brain, a manometer, to directly measure the pressure, and it will give you a number in millimeter mercury. How much is the pressure? This is called intracranial pressure monitor or invasive monitoring. Now, how can we justify this procedure? I mean, when do we do this? First, the patient should have decreased level of consciousness to justify it. Second, the patient should have any abnormality in the CT, which explains this decreased level of consciousness, in order to justify monitoring by invasive way. Why is that? Because coma can happen, for example, due to medical condition, due to hypoglycemia, hypertension, any reason. So in order to justify invasive monitoring of the intracranial pressure, the patient should have decreased level of consciousness with abnormal CT brain. Decreased level of consciousness with abnormal CT brain. Now, to make the thing more complex, what if the patient comes from head trauma, the patient has decreased level of consciousness, but the CT brain is normal? Actually, statistically, even if the CT brain is normal, still 13% of the patients can have increased intracranial pressure. I mean the traumatic patients. So what should we do in this case? If the patient has decreased level of consciousness from trauma and with normal CT, in this case, we add more criteria in order to justify the insertion of the intracranial pressure monitor. And this criteria is 2 out of 3. Age above 40 years, systolic blood pressure below 90 millimeter mercury, decerebrate or decorticate posturing on motor exam, unilateral or bilateral. So those 3 things: age above 40, systolic blood pressure below 90 millimeter mercury, and decerebrate or decorticate posturing. Any 2 of those 3, in addition to decreased level of consciousness in normal CT brain, can justify insertion of invasive intracranial pressure monitor. So again, if the patient comes from head trauma and has decreased level of consciousness with abnormal CT, invasive intracranial pressure monitor is justified without any further criteria. Okay? If the patient has decreased level of consciousness from trauma with normal CT brain, we need to have more criteria to justify intracranial pressure monitor, and those are 2 of 3, as we said. So, what are the relative contraindications for invasive intracranial pressure monitor? If the patient is awake, this is relative contraindication, because if the patient is awake, it's easy to monitor the level of consciousness of the patient without invasive monitoring. Even if the patient is fully awake, for example, Glasgow 15 or 14, even the family, even the non-professional can notice any decreased level of consciousness. Okay, so if the patient is fully awake, this is contraindication. And if the patient has coagulopathy, because invasive monitoring can lead to bleeding in case of coagulopathy. Now, what is the most common trauma-induced coagulopathy? It is the DIC, disseminated intravascular coagulation. So be aware of that in multi-trauma patients. The peak of intracranial pressure in trauma is from day 2 to 3 and from day 9 to 11. This means that if after discharging the patient home, if the patient comes in day 9 or 10 or 11, be aware there may be some rebound phenomenon of increased intracranial pressure. What are the types of invasive intracranial pressure monitor? We have the intraventricular catheter, the intraparenchymal monitor, the subarachnoid screw or subarachnoid bolt, the subdural catheter, and the epidural monitor. Notice that in infants, we don't need any of those, because just what you need is to palpate the fontanelle. You don't need to be invasive. Just put your hand over the fontanelle of the infant. You get an impression. If it is bulge and tense, this means increased intracranial pressure. If it's soft and lax, this means that the intracranial pressure is normal. That's why in infants, we don't need those. In infants with open fontanelle, we don't need those invasive types of monitoring. What about the intraventricular catheter? Intraventricular catheter monitor is the most accurate one. It even can monitor the intracranial pressure from second to second. It can give you a curve, like a curve of ECG of intracranial pressure. So it's the most accurate and the most prompt one. But intraventricular catheter monitoring is not practical in trauma patients. Why? because in head trauma patients, usually the ventricles are small in size, it's difficult to get there, and the CSF amount is usually low, and it's not enough to monitor the intracranial pressure through it. That's why we use the other methods here in trauma patients, especially the intraparenchymal monitor, what is available to monitor the intracranial pressure by it. As we said, the intraventricular catheter is better, is more accurate, but it's not practical usually in trauma patients. That's why we use other methods. There are some adjuncts to intracranial pressure monitoring. For example, the jugular venous oxygen monitoring, the brain tissue oxygen tension monitoring, the bedside monitoring of regional cerebral blood flow, and a cerebral microdialysis. Those adjuncts are something advanced. They are not available everywhere. They are available just in some centers of the world. If they are there, they are good, but usually we don't find them everywhere. And the good thing about those adjuncts is that they not just measure the intracranial pressure, but they also measure the metabolic status of the brain, which is the end point. The aim of treating intracranial pressure is the cerebral blood flow and the metabolic condition of the brain. So by those methods, you monitor the end point, the metabolic activity of the brain, the metabolic effect of the intracranial pressure on the brain, which is very useful if it's available. Now, what are the aims of treating intracranial pressure or traumatic brain injury patients? Usually, we need to keep the intracranial pressure from getting high, prevent intracranial pressure from going high. What is meant by high? How much is high? Actually, there are some variability. Some books, it says it's 15 millimeter mercury. Some say it's 20 millimeter mercury, and some say it's 25 millimeter mercury. So it's not a sacred number. That's why we should add the clinical sense and the clinical presentation to this number. And if you have adjuncts also, you should add it to the intracranial pressure in order to decide whether the patient has increased intracranial pressure or not. If you just have the number of intracranial pressure, you don't have adjuncts, you don't have clinical feature, you can use the number 22 millimeter mercury. If the intracranial pressure goes above 22 millimeter mercury, you should treat the patient to get the intracranial pressure back to normal. As we said, use the adjuncts and the clinical scenario. For example, if the patient, for example, has intracranial pressure of 17 millimeter mercury, which is below 22, but the patient is deteriorating, so treat him as if he has increased intracranial pressure. Or if the patient has adjuncts of monitoring and they are not good, treat him as increased intracranial pressure. But if you just have the number, use the 22 millimeter mercury. So the treatment should be based on intracranial pressure in combination with the clinical examination and brain CT findings. We should avoid the cerebral perfusion pressure from getting below 50 millimeter mercury. Why? To prevent brain ischemia, to prevent anoxic brain damage. And also, we should avoid increasing the cerebral perfusion pressure above 70 millimeter mercury. Why? Because the traumatic brain has vasomotor paralysis, so the range of controlling of the range of autoregulation is narrow. It's just between 50 and 70 millimeter mercuries. If the cerebral perfusion pressure is below 50 millimeter mercury, it will lead to ischemia. If the cerebral perfusion pressure is above 70 millimeter mercury in traumatic brain, it will lead to vasogenic edema and hyperemia. That's why we should control the blood pressure in order to keep the cerebral perfusion pressure between 50 and 70 millimeters of mercury. How to calculate that? You have intracranial pressure monitor, it's a number. You have the mean arterial pressure measurement, which is a number. You subtract the intracranial pressure from the mean arterial pressure, you get the cerebral perfusion pressure, and you should treat the blood pressure accordingly to keep the cerebral perfusion pressure between 50 and 70 millimeters of mercury. So as we said, keep the intracranial pressure below 22 millimeter mercury, keep the cerebral perfusion pressure above 50 millimeter mercury and below 70 millimeter mercury. Now, how to treat the increased intracranial pressure? If the patient develops high intracranial pressure, how to manage? Actually, there are several measures. One of them is elevate head of bed between 30 and 45 degrees. Why? To enhance the venous outflow from the brain, and this will enhance the intracranial pressure. And actually, this is very important. It can make a big difference. A simple thing, increase the head of bed, can make a big difference for the patient. But be aware, the priority is for A, B, C, then D. So if the patient is hypotensive, do not raise the head of bed. If the patient has hypotension, do not raise the head of bed, because C is prior to D. Remember that. If the patient has hypotension, you should raise the patient's leg, not the head. So the first thing, if the patient has normal blood pressure, elevate the head of bed 30 to 45 degrees. Keep the neck straight and avoid kinking. Why? To make the jugular vein smooth. If the patient has a kink in the neck, for example, he may have a pressure in the jugular vein, and this will impede the venous outflow from the brain, and it will increase the intracranial pressure due to the back pressure of the jugular vein. That's why keep the neck straight and keep the soft tissue of the neck from anything tight. We should not have anything tight on the soft tissue of the neck. It should be straight and smooth. And care should be given to the neck collar. Neck collar in multi-trauma patient is mandatory, but neck collar should fix bone over bone, mandible, mastoid over the chest, the clavicles, and the scapula. So the good position of the neck collar is bone over bone. It should not compress the soft tissue of the neck. If it compresses the soft tissue of the neck, it will lead to compression over the jugular vein and increase intracranial pressure. So that's why you should be aware, you should be conscious about the position of the neck collar to be in a good position, just bone over bone. And also anything which constricts the neck, like the band, which is the tie, which is used to fix the endotracheal tube, be aware not to be on the soft tissue of the neck. Avoid hypotension, control hypertension, avoid hypoxia, ventilate to normal carbia. If the patient has hypercarbia, the patient has hypercapnia, you should correct the ventilator setting in order to keep the CO2 between 35 and 40 millimeter mercury. As you know, the normal CO2 is between 35 and 45 millimeter mercury. But in the case of brain insult, we need it to be at the lower level of the normal, which is 35 to 40 millimeter mercury. Light sedation can be used to decrease the metabolic activity of the brain and to decrease the Valsalva maneuver. and this will decrease the intracranial pressure, but be cautious. Sedation is contraindicated if the patient is hypotensive. And as we said, C is prior to D. There is some controversy about the use of prophylactic hypothermia for decreasing the intracranial pressure by decreasing the metabolic need of the brain. So there are some controversy about it. At least the patient should not be febrile, because if the patient is febrile, he will have increased metabolic demand of the brain, which makes the things worse. At least the patient should be normothermic, and there is some controversy about inducing some mild prophylactic hypothermia to decrease the intracranial pressure. Any patient who has unexpected decreased level of consciousness or unexpected increase in the intracranial pressure should have a new CT, even if the CT is recent, even if the CT brain is recent. If the patient develops suddenly increased, unexplained increased intracranial pressure, which is not explained, the patient should get a new CT. Remember that, because a new thing may happen in trauma patient. Heavy sedation can be used if light sedation is not enough, given that the blood pressure is normal. We can drain some CSF if the patient already have a drain, if the patient already have an EVD, an external ventricular drain. Hyperventilation to some hypocapnia from 30 to 35 can be useful in decreasing intracranial pressure. However, hyperventilation, hypocapnia can lead to cerebral ischemia. So how to solve this issue? How to solve this issue? Hyperventilation can be used, but for short time. Hyperventilation can be used for short time, just for a few minutes. Do not exceed that, because prolonged hyperventilation will lead to vasoconstriction and cerebral ischemia. So you can use hyperventilation, which is good. It can decrease the intracranial pressure, and it can decrease it rapidly. It has a rapid onset of action. So you can use it to temporize until other methods work, but do not use it for a long time. This is the rule. Mannitol, as you know, is an osmotic diuretic. Mannitol can withdraw the fluid from the brain parenchyma into the intravascular cavity, and by this it can decrease brain edema and decrease intracranial pressure accordingly. So mannitol can be used to decrease the intracranial pressure. The dosage is 1/4 to 1 gram of mannitol per kilogram of the patient. How mannitol acts on the brain? It acts by withdrawing fluid from the brain. How mannitol acts on the kidneys? Mannitol is an osmotic diuretic. Mannitol is filtrated by the kidney, but it is not reabsorbed. It's filtrated, but not reabsorbed. So it's an osmotic diuretic. So mannitol is contraindicated if the patient is hypotensive, because it's a diuretic. It can lead to aggravation of hypotension. Okay? And as you remember, C is prior to D. So if the patient is hypotensive, do not use mannitol. What about the hypertonic saline? So we can use hypertonic saline 23.4%, not the 3%, the 23.4% of hypertonic saline can be given. It acts on the brain the same thing as mannitol. It withdraws fluid from the brain and decreases brain edema. So it acts almost the same thing on the brain. But on the kidney, the issue is different. Hypertonic saline is a saline. It's a volume expander. It is filtrated, but the salt is reabsorbed. It's reabsorbed. It's a salt. So it's filtrated and reabsorbed. So it's not a diuretic. It's not an osmotic diuretic. That's why if the patient is hypotensive and in the same time has high intracranial pressure, the drug of choice is hypertonic saline. Okay? Because it can increase the blood pressure by volume expansion and at the same time can withdraw fluid from the brain. On the other hand, if the patient has high blood pressure with high intracranial pressure, mannitol is good because it's a diuretic and can decrease the blood pressure and decrease the intracranial pressure at the same time. So it depends on the blood pressure. Choosing mannitol or hypertonic saline, they act the same thing on the brain, but not the same thing on the kidney. Augmented hyperventilation if the case is severe. And the last thing is the surgical treatment. Now, we have two types of surgical treatment. It's either targeted treatment to the lesion, to remove the lesion, for example, epidural hematoma, subdural hematoma, hydrocephalus. So it's a targeted surgical treatment for the lesion or a decompressive craniectomy. Let's explain by some example. For example, if the patient has high intracranial pressure due to epidural hematoma, what is the treatment? The answer is the treatment is surgery. Surgery. It's not the medical treatment. Medical treatment can be used just for temporizing until the patient reaches the operation theater. But the definitive treatment is immediately emergency surgery, craniotomy, and evacuation of the epidural hematoma. What if the patient has high intracranial pressure due to subdural hematoma? The answer is the same. The treatment is surgery. The treatment is immediate surgery. What if the patient has high intracranial pressure due to hydrocephalus? What is the treatment? The answer is the same. The treatment is surgery. Insertion of external ventricular drain to drain the CSF. Okay? So, in case the cause of intracranial pressure is surgical, is a targeted surgical lesion like epidural hematoma, subdural hematoma, hydrocephalus, the treatment is immediately surgery, not a medical treatment. However, if the patient has, for example, brain contusion, there is no specific surgery for brain contusion. You will not go and excise the brain contusion with the brain parenchyma. There is no specific surgery for this lesion. What if the lesion is brain edema? There is no specific treatment for, there is no specific surgical treatment for brain edema. So, if the patient has brain contusion, has brain edema causing high intracranial pressure, what is the treatment? The answer is medical treatment. Medical treatment. Head of bed elevation, hypertonic saline, mannitol, hyperventilation, sedation, etc., etc. So, if the patient has something which cannot be excised by surgery, there is no specific surgical treatment for it, like brain contusion or brain edema, that treatment is medical. not surgical. The treatment is usually medical. But what if the medical treatment fails? What if you do every medical treatment for the patient and the patient does not improve? You hyperventilate, you give hypertonic saline, you give mannitol, you give sedation, and still the intracranial pressure is high. So what's the treatment? Then we go for this decompressive craniectomy. What is decompressive craniectomy? In decompressive craniectomy, we open the skull, we remove the bone, we open the dura, we keep the dura open, we keep the skull open, we just close the scalp, the gallia, and the skin. So we remove the bone, we open the dura, we keep the dura open, and we keep the skull open, and we just close the scalp, the gallia, and the skin. This is decompressive craniectomy. And by decompressive craniectomy, we change the intracranial cavity from a closed cavity to an open cavity, from rigid cavity to elastic cavity. You change the cavity from rigid cavity to an elastic cavity. It becomes like an abdominal cavity or the chest cavity, etc. So, to sum the things up, again, if the patient has high intracranial pressure due to epidural hematoma, subdural hematoma, hydrocephalus, the treatment is immediately surgery specific for this type of pathology. If the patient has high intracranial pressure due to brain edema or brain contusion, there is no specific surgery for those. The treatment is medical. But if all the medical treatment fail, we go to decompressive craniectomy. Okay, so that's now we finished our lecture about the intracranial pressure. And if you have any question, do not hesitate to ask me.